Okay.
Yeah. Hi, good afternoon,
Okay.
everyone. Welcome to session 2. We're very pleased to have you here. We're starting off the meeting with 71 persons so far, so that is great. Special welcome to our colleagues from Caribbean islands as well, Antigua, Barbados, Jamaica, St. Lucia, St. Vincent. So we have such a great turnout from all the different islands today. Before we start, I just wanted to thank TTOA for their support and assistance with the GOC credits. I also want to thank ICU Optometrist for supporting this virtual event. Please note that the feedback forms and CET sign-in sheets are posted at the top of the chat. And most of you would have gotten emails with those links as well. So I'll just turn you over to Dr. Kumar, who would be our moderator this afternoon.
Thank you, Anura, and welcome to everybody for second session of our Optometrist lecture series of 2021. I hope all of you are keeping safe and making sure you and your families are looking after yourselves. So we have a packed evening, and it's wonderful to see so many of our colleagues giving up their time to join us for this meeting. And I hope it is rich and entertaining and also a lot of learning to take home. We have, to start with, we have case presentations, and then we would have a main talk by Dr. Bola. And the first presenter for this evening is our own Retinal Rajkumar. So I am going to bring her on. While she's setting up her presentation, I would like to just give a few comments about her, that she has graduated in 2018 and currently working with us at CVRS. And I've had the privilege to work with her and being affected by her infectious nature of learning and very enthusiastic approach towards patient care and in coming up with a lot of ideas. And she also impresses upon me the fact that she's currently doing her MSc from Aston University in UK. So very enthusiastic, very motivated, and a keen student to learn. So Retinal, the floor is yours. Thank you very much for contributing to this meeting.
Thank you, Dr. Kumar. Good afternoon, everyone. Thanks for being here with us today. It's so nice to see so many people here. I hope that all of you are doing well and staying safe, and I hope that you enjoy the presentation. Right. So today I'm going to be doing a review of 2 macular cases and just a brief discussion on whether or not we think referral or surgery might be a good idea. So the first case, we have a 68-year-old female who was referred from the diabetic eye screening program. She had no complaints. Her medical history was positive for diabetes and high blood pressure for the past 20 years, and she's currently taking metformin and atenolol to regulate. The only significant ocular history was right pterygium removal about 20 years ago, but nothing else to note. And just taking a look at her visual acuities, in the right eye unaided, she was 20/80 and the left eye 20/200, with pinhole of 20/30 plus 2 in the right and 20/20 minus 2 in the left. Her current glasses prescription was plus 250 with a minus 275 still, and that corrected her to 20/30 minus 2. And then in the left eye, prescription of plus 5.25 with a minus 2 still, and that corrected her to 20/20 minus 2. On doing refraction at the initial visit, I found that the prescription didn't really change much. So I found a prescription of +2 - 0.75 in the right and a best corrected VA of 20/30 +2. And in the left, a prescription of +5 - 2 with a best corrected distance VA of 20/20 -2. And finally, the pressures were 17 and 20 in the right and left, respectively. So our anterior segment findings, everything was fine except for cataract in both eyes. The right eye had NS3+ and PSC1+, and the left eye had NS1+ and PSC1+. So moving on to the posterior segment findings. So these are fundus photos of the right and left eye respectively. On the right side, overall, you could actually see right off the bat that the view is a little bit hazy when you compare it to the left eye. But otherwise, the right side looked relatively normal. However, when you look at the left eye here, you could actually see a sort of whitish membrane in this area here, just inferior nasal to the fovea. And so I'm just gonna circle it so you can see it better. It's circled by this blue ring here. And some things to note, if you look at the vessels, as you go closer to the fovea, you can see that they appear to be a little bit tortuous. And then you could also see in this area some retinal folds that form a sort of radial pattern around the fovea. So we went on to the OCT angiogram of both eyes. On the left-hand side, you could see this is the right eye here, and everything looks relatively normal. So the retinal layers look fine. The contour of the macula and fovea here look fine as well. And the vessels on the angiogram also look okay. But when you go over to the left eye now, there are a couple of things to note. The first one is this red arrow here. It points to a sort of a hyperreflective membrane here overlying the internal limiting membrane, and it causes a sort of wrinkling effect on the macula. When you look at the green arrow, you could see it pointing to some very tortuous blood vessels in the inferior nasal region of the macula. And this is usually because the membrane actually pulls on the retinal blood vessels, which gives it that distorted appearance. So this now is a cross-line scan of both eyes. Again, the right eye looks relatively normal. When you look at the left eye, this yellow arrow points to a very faint line that is coming off of the retina, but still attached to the retina. And that is a partial vitreous detachment. And then we go on to the retinal thickness map. This one compares the right to the left eye. When you look at the right eye here on this side, you can see all of the quadrants within the green region, which means that it falls within the normal or average retinal thickness. The only thing of note that I could see was this very faint line over the retina that looks like it could be the start of a PVD, but there's nothing really to worry about at this point. When you look at the left eye now, looking at the map here, you could actually see in the inferior and nasal region, the retina actually appears thicker, and that's indicated by the yellow and red coloring, as opposed to the green, which is within the normal. Just looking at the scans side by side, you could actually tell that the retina in the left eye appears to be thicker when you compare it to the retina in the right eye. And another thing to note is that the foveal depression actually appears a little bit raised in the left eye. And that's because the membrane is essentially kind of pulling on the fovea, so it kind of elevates it. So just to kind of give you an example, idea of how the layers of the retina, the thickening actually correlates to the findings on the fundus. So here you can actually see the membrane, again, in the inferior nasal region of the retina. And then when you kind of overlay the retina map, you see that most of the membrane actually lies within the inferior nasal part of the retina. with the superior temporal part of the retina remaining unaffected. So our final diagnosis in this case was a left epiretinal membrane with macular pucker and bilateral cataracts in the right eye more than the left. So let's have a discussion. So I'm gonna present a couple questions about the case, and I'd really like it if you all could give me your thoughts and opinions on it. So feel free to raise your hand or message in the chat box. So based on the first case, the first question I'd like to ask is whether or not we should do surgery for the epiretinal membrane in the left eye. So first we need to look at all the facts. So in this case, the patient is asymptomatic. She didn't really have any problems with her vision. Her visual acuity was 20/20 -2 in that eye with the membrane. She had no distortion in vision. And the final point is that it had no involvement of the fovea or the central fovea. So would anybody like to give me their thoughts or opinions on this case and what we should do? Anyone at all?
I'm hoping for some answers, Renelle. Let's see it. Monitor patient. Stephanie says monitor the patient.
Okay.
Dr. Boringer says I would monitor. Very good.
That's
good.
Very nice to hear your views. So I'm just going to ask someone on the panel, Dr. Bula, do you mind giving me your opinion? Do you think we should do surgery for the ERM?
Well, I think these cases are a little tricky because it really depends on a lot of little factors. And one would be the discussion that you have with the patient. So yes, all these pointing towards, no surgery, and it points towards no surgery because you can't give them better vision with surgery than 20/20, right? They already have good vision and they're already saying they have no problem. So you really need to tell them, have that discussion and tell them what you're finding on the retina. And then, they usually ask a lot of questions. One of the questions they ask you is, if I leave this thing, would my vision get worse in a year, 2 years, 3 years? So I think it's not only that we wouldn't do surgery, but there's a lot of other things involved. But I agree with Vineet and the panel that, and the other guys, that it's looking like no surgery, left eye for ERM.
Okay. Thanks, Dr. Bula. So I have to agree as well. As Dr. Bula was saying, the patient is basically 20/20 in that eye. So it doesn't really, warrant having to do surgery at this point in time. But a discussion is important with the patient. Right, so the second question, again, if you saw the patient in your optometric practice, which of the 3 following options would you take? So the first one is, would you manage the patient without a referral? The second one is if you would telemedicine with, say, a vitreoretinal specialist. And the third one would be whether you would refer to the specialist. So again, there's no right or wrong answer really. So I encourage you to give us your thoughts or your opinions. So what do you think?
Stephanie says refer to specialist as precaution. And I'm looking for some more comments. I'm waiting. Depends. Dr. Boringer says depends on your comfort zone. And Rashmi says I would refer. Currently based, I would refer as well. So refer to specialist. So the large number of feedback is referral to the specialist to be safe.
Yeah, thanks for that, guys. So again, I'm gonna go ahead and ask someone again. I'd like to ask Ibrahim if you could give us your thoughts on this.
I would think referral would be a good idea to confirm. However, if you have an OCT available in practice, you can do the scans and consult with the ophthalmologist virtually via telemedicine.
Yeah. So I think, well, I agree with Ibrahim. So I think that's a good idea. As I said, I don't think there is any right or wrong answers. And Dr. Boring actually made a good point, depending on your comfort zone. So it's a good idea to refer, just to be sure. But if you have an OCT, you could definitely use that to your advantage. And, in these COVID times where a patient may not want to necessarily go, from place to place, it might be a good idea to just send an OCT scan and just get a consult. Anybody else on the panel wanted to add anything?
I would just join in with some additional information as well, Renal. It's useful in particularly epiretinal membranes to refer to these specialists simply because it's good to have a thorough check of the periphery of the retina to see if there is any contributing cause for the epiretinal membrane. Although the large number of epiretinal membranes are idiopathic, sometimes patients may have had surgery in the periphery, such as laser treatment, or have had an injury in the past, etc. And they would benefit from a thorough vitreoretinal assessment. And then that would allow us to manage it going forward.
Okay, thanks, Dr. Kumar.
So there's a question that's been asked. Is can you remind me what the right eye visual acuity was with the cataract?
The right
2030.
Yeah, 2030. That's correct. Yeah.
So I Dorian Dwarka speaking here. So I echo Dr. Kumar's sentiments as well, because a full examination is required, and there might be other coexisting pathology that was a little more easily picked up by the retinal specialist than in the normal setting in the clinic.
Okay.
Thank you, Dr. Dwarka.
I have a question to the retina specialist. So when would you, ERM are very common really. When would you decide to do surgery on it? Basically, weighing up the risk or the benefits. Do you have any criteria or anything be interesting to know?
Yes, Dr. Boringa, we will talk about this. I think Dr. Bola is going to talk about this in his talk.
Okay.
So we will go through this in detail.
Okay, so moving on. So another question now, should cataract surgery be done on the right eye? So looking at the facts again in the case, the patient is asymptomatic. She didn't need new glasses because the prescription didn't change that much. And she's anisometropic. So on the right eye, she was +2, on the left eye, she was +5. But there is significant cataract. It was NS 3+, I think, which reduced her vision to 20/30. So does anybody have any opinions on that or would like to give their thoughts?
I'd bring in Dr. Dwarka to start with. Any comments, Dr. Dwarka?
So thanks, Dr. Kumar. This is again another question that you need a consultation with the patient so that they sort of understand in a way what you're speaking about. Remember, cataract surgery is not an emergency, and it's usually done when the patient is ready to have it done. It's a patient-driven surgery. And most patients would like to hear their options. The options being, what will happen if we leave it alone? Then we need to decide from how the patient is functioning, whether or not they have any sort of impairment of their daily activities, hobbies, professions, and so on. And then based on that, we could give them the choice that is most applicable to them. We must bear in mind the patient is anisometropic. They're also hypermetropic in both eyes. As an ophthalmologist and a cataract surgeon, I can give them a very high quality of vision with a high success rate by removing their lenses and bring them pretty much close to emmetropia. But this is not always in the patient's best interest. And the patient's best interest usually has to be something that the patient is happy about once they understand the surgery. So it's not a simple clear-cut thing. It requires discussion and some investment and some time so the patient can understand the state of what is happening to their eye.
Thank you, Dr. Dwarka. I think you summarized what our opinion is on this subject, because it's not an easy decision, but the key thing is actually consultation and discussion with the patient as to what their needs are would be the way forward to manage this interesting patient, Renel. Dr. Bola, do you have any comments?
Yeah, Vineet. I'm glad you brought me in, man. Let's say you did do the right cataract, and then you think, well, oh, now she's come out -1 on the right eye, and she's a little bit unhappy with the large anisometropia, and you decide, oh, well, I better do the left eye to kind of balance her up now. Would you do, Vineet, the cataract and the retinal macular membrane in one surgery, or would you just do the cataract?
Thank you, Dr. Bola, for putting me on the spot. So based on what Renel has provided us information with the OCTs and what is going on with particularly the macula and the fovea in particular, I would say that I would offer this patient first cataract surgery only, and then monitor the epiretinal membrane. And if there is distortion subsequent to cataract surgery, I can address it as an independent operation. Does that answer your question, Dr. Bola?
Yes.
Yeah. So I would, because I think they would not manage the anisometropia. They would struggle with that. And as you rightly pointed out, that is one big issue that we have. And explaining to the patient the situation, because all the refraction is always useful to see whether the epiretinal membrane is contributing to her prescription is an important thing to make note of. But as Renel has pointed out, there isn't a huge change in the fovea for it to contribute. So we presume that this is how she has always been with her prescription. Got a question from Dr. Goringer.
I just think you could go two ways, you know. So you could remove the membrane and do the cataract in one surgery, and it's because epiretinal membrane peeling has such a low complication rate these days with the new modern way we remove them, that you could add that to the surgery and still, you know, be pretty confident that you're going to get a good result, just like your cataract surgery alone these days. So I think you could go either way, you know, Ben, but I agree. I may just remove the cataract.
Okay. Wonderful. Right.
Just Vineet, with a 20/20 vision level in the eye with the epiretinal membrane, unless the patient is highly motivated to have it done, most of us would probably just in passing say it is possible to do so, primarily because if the vision was noticeably decreasing and we were, let's say, dropping down to about a 20/40 over the period of observation, then we'd probably have a stronger case for the combined surgery.
Correct. Okay.
Thanks
Right.
so much.
Okay.
Anybody else have anything to add? Okay, so I'm just gonna move forward now. So finally, how did we manage the patient? So we discussed the option of surgery for the epiretinal membrane in the left eye, as well as the option of surgery for the cataract in the right eye. So we discussed everything with the patient. She didn't need any change of glasses. And then ultimately what we decided was to review the patient in 6 months with a repeat OCT.
Thank you, Renel.
That was in case 1. Yes. Yeah. So we're going to just go on to case 2 now. So in this case, we have a 72-year-old male who presented to us with with complaints of blurred vision in the right eye. He mentioned to us that he thought he had a cataract in that eye. He had no significant ocular history or medical history. And looking at his VAs, aided in the right eye with 20/40 -2 and 20/25 in the left, unaided with 20/80 in the right and 20/60 in the left, with pinhole of 20/50 in the right and 20/25 in the left. The eye pressures were 13 and 17 in both eyes. So again, looking at the anterior segment findings, everything was normal besides NS2+ in both eyes. They look to be about the same amount or the same, yeah. And now going on to the posterior segment findings, we had an OCT scan done of the back of the eyes, retina, and there are a couple things to note here. So the first one is where you see the red arrow pointing on this red-free scan is an area of retinal thickening. The second point to note is the blue arrow here shows a hyperreflective membrane over the ILM. It's a little bit difficult to see in this one, but it's definitely over the ILM there. And the third point to note is that the yellow arrow here actually shows inversion of the fovea. So inversion of the fovea simply meaning that the contour of the fovea is actually flipped or mirrored. So instead of it having the dip that we would normally see or that we're accustomed seeing, is actually the opposite. So that's what we call foveal inversion. And it's usually because the ERM or the membrane is pulling on the fovea. Right, so this was OCT of the left eye now. So again, the same thing here. The red arrow shows thickening of the retina on the red-free scan here. The blue arrow shows a hyperreflective membrane on the ILM, which causes wrinkling. And here you can actually see the membrane a little bit better. And then again, the yellow arrow shows foveal inversion. So our diagnosis in this case was bilateral epiretinal membranes with macular pucker and bilateral cataracts, NS2+ in both eyes. So discussion time again. The first question is whether you think surgery would be a good idea for the ARM in this case. So looking at the facts again, the patient was symptomatic. VAs were reduced and to 20/40 -2 in the right eye. And there was foveal involvement in both of the eyes this time. So could anybody want to give us their thoughts on that?
Yeah, I'll start off with Dr. Dwarka. Dr. Dwarka, are you there? I think while he comes back, Dr. Bola, your thoughts?
I think this one a little more clear-cut than the other one. You know, with the vision being down, the retina being involved, and the patient having, well, the symptoms we would assume it's metamorphoxia, which usually responds well to surgery. So I would be leaning towards surgery if the patient is amenable to the idea of having surgery.
Excellent. And I would agree with that. Dr. Dwarka, are you there?
Yes, my apologies. I just didn't unmute the microphone. I agree totally. This is a lot more clear-cut. The membrane is also a very aggressive looking thing, and we have definite visual symptoms. So no problem in hinting to this, strongly suggesting in my professional capacity that this patient should in fact embark on a surgical course.
Wonderful. Right. Anybody has any comments or questions? Anybody, any other colleagues of ours? Okay, I'll move to the next question, Renelle.
Thanks.
You have another question?
Yeah. So in this case, I just the surgery, as the doctor said, was would likely give visual improvement. So the next question is, do we do surgery on one eye or do we do surgery on both eyes? So again, the right eye was reduced to 20/40 minus 2 corrected. The left eye was corrected to 20/25, which is not too bad. The patient is symptomatic for the right eye, and there's foveal involvement in both of the eyes. So anybody want to give their thoughts on that, or?
I think I'll bring back Dr. Bola again. Your thoughts? You probably go for the right eye.
Yeah. I'll go for the right eye, leave the left eye for now, see how that right eye goes. And then, depending on what the patient thinks, we decide what to do with the left eye. Now, the left eye is a little more tricky because the vision's better, asymptomatic. But the thing is, when we look at the OCT, the retina architecture is affected, which means if you leave that membrane over time, we would expect a reduction in the vision. So I think you're taking a risk by leaving the membrane in that one because of the amount of change on the retina.
Thank you for pointing that out, Dr. Bola, because I think Kendrick Boyson has asked that question. Would the removal of the ERM affect the inverted fovea, or is additional intervention needed? So the membrane removal would improve the inverted fovea. And as Dr. Bola pointed out, it depends on how long it has been there for. And the recovery of that also takes time. And I think Dr. Bola will address that issue when he speaks and gives you further information. So we will answer that question for you guys.
Thanks.
Wonderful. Okay.
Thanks, guys. So moving on. So again, I would say right eye surgery would probably be a good idea as the patient had symptoms, but it could probably be discussed for the left eye with the patient after. So another question, what type of surgery would normally be done for ERM? Anybody want to give their opinion? So either raise your hand or you can message in the group chat.
I think the standard surgery that we tend to do if the patient has cataract, Retinal, is remove the cataract, vitrectomy, and epiretinal membrane peel. And sometimes we also include, if there is the ILM that exists with the ERM, you tend to remove that as well. That's what we tend to do.
Yes. So yeah, normally it would be a vitrectomy done with hyaloid peel, ERM peel, and an ILM peel. It's something that we call a triple peel, an easy way to remember it. So on this slide, we have a video of a triple peel procedure that was done by Dr. Bola. So I'm just gonna play it. Let me know if you all hear the audio.
Injection
Not hearing the audio.
For hyaloid elevation. Hyaloid detached to confirm with triumphant alone. Injection of membrane blue. Membrane blue removed. Epiretinal membrane peel with a 25 gauge platform forceps. Peel completed up to arcade. Injection of brilliant blue. ILM peel completed up to arcade. Fluid gas exchange.
Did you all hear it?
Yes.
Yeah, okay. Great.
Excellent video. Thank you, Dr. Mohammed and Dr. Bola for that, and Retinal for showing that.
Right, so another question, the final question is, should we remove the cataract surgery as well? The cataract as well. Dr. Kumar hinted on this a little bit, and Dr. Bola also commented on it in the first case. So again, in this case, the cataracts are moderate. They were grade 2, I think. The options, normally, the first one would be deal with the epiretinal membrane only and leave the cataract alone. The second one would be combined surgery, where you do cataract surgery and then surgery for the ARM in one procedure. And the other option would have been to remove the cataract first, then do surgery for the ARM at a later date. So they all have their pros and cons. And I just did a little table with it. It's not all the pros and cons, but some of the main ones. So if you were to do a vitrectomy only just for the ARM and leave the cataract alone, the main thing is that the ARM gets removed, which is what is causing most of the visual problem. And also it could be the more affordable option for the patient at a given point in time. But the cons are almost 100% of patients who have had a vitrectomy would require cataract surgery in the future. And another con is that you have a higher risk of cataract surgery complication in eyes that have had a vitrectomy previously. The second option is doing combined surgery, phaco, emulsification for the cataract plus a vitrectomy. And this spares the patient from a future procedure with its own separate costs and recovery processes. And a really good thing about this is that having the cataract removed first actually improves visualization for more detailed retinal work by the surgeon. The main one is that there's a risk of IOL displacement during the vitrectomy, as doing the cataract surgery just before the vitrectomy, the IOL wouldn't normally have time to fibrose into the bag as it normally would. And the second con is that post-op recovery could be variable. The other option is removing the cataract first and then doing ERM at a different date. So the pro of this is having, a clear view by the surgeon if you have the cataract removed first. But the main con is that the patient has to undergo 2 separate surgeries with 2 separate recovery processes and costs. So in this case, we decided to do combined surgery for the right eye cataract and ERM. And that was the eye that the patient had more problems with. And then we actually did combined surgery for the left eye cataract and ERM upon the patient request, because he had good results from the first eye, from doing the right eye. So these are some pre and post-op scans of the right eye. It's actually a nice visualization of the post-op recovery process. So this first picture here was taken on the 18th of February, and this was before surgery. So the pink areas here, you could actually see that that's areas of retinal thickness, so almost the entire macula. And when you go to the second scan, which was taken 2 months after surgery, you could actually see a resolution of the thickening already. So that's indicated by the orange and the green regions. So you actually get the thickening resolving. And then again, 1 month later, just taken last month, you actually see even more resolution of the retinal thickening. So this entire area here is in the green or normal limits of retinal thickness. And at the bottom, we have a nice, just a nice little graph showing that the thickness was actually resolving with time. So the retina was decreasing in thickness. So it's important to know that the best corrected visual acuity in that eye was actually 20/25 + 2, as compared to previously before surgery, it was 20/40 - 2. Another important thing to note is that visual recovery usually comes 2 to 3 months after ERM peeling. However, improvement can continue for 6 to 12 months after, before best final vision is obtained. So I really like this diagram. It's a nice indication of how well the ERM, how well it resolves after surgery. So we're gonna just compare the 2 cases. So in the first case, we have a patient with an epiretinal membrane in the left eye. The patient was asymptomatic and had a best corrected VA of 20/20 - 2 in that eye with ERM. And another thing to note was that it had no foveal involvement in that eye. When you look at case 2, you have a patient with epiretinal membranes in both eyes. The patient is symptomatic for the right eye, and the best corrected visual acuities were 20/40 -2 in the right, and there was foveal involvement in both of the eyes. So in case 1, we opted to do no surgery and monitor, as the patient had no symptoms and there was no foveal involvement. But in case 2, as the doctors were saying, it was a more clear-cut case, so surgery was a good idea for the right eye particularly, and even for the left eye if the patient, wanted that option. So these are just some of the take-home notes from the entire presentation. In mild to moderate cases of ERMs and cataracts, visual acuity and visual symptoms are very important determinant factors in the management plan, specifically deciding whether referral and surgery is necessary. So it's important to look at the whole picture, not just the clinical findings. And another thing is telemedicine is an efficient tool that we can use to consult with specialists on cases that might be tricky. So these are my references, and that was the end of the presentation. So does anybody have any questions before we go to the panel?
Excellent, Retinal. That is very, very useful cases. And I think we've had a good discussion as we went along when you presented your questions. Just being mindful of the time, and we have a few presentations, I would pick up questions a little later. But once again, thank you. Any quick comments, Dr. Bola and Dr. Dwarka? Quick comments while I get Ibrahim to get ready with this presentation.
Yeah, just one comment, Vin. I think, Retinal, you've done an excellent comparison between these two cases that really drives home the point when to operate. And that's really, really great to see how you put the cases together to demonstrate that. What is interesting, Vin, was when we originally started to look at doing refractive outcome type cataract surgery, where people want to get these multifocal lenses and toric lenses and stuff. We were more thinking that we should do these in eyes that didn't have ERMs and didn't have any pathology. But now what we could do is, with the advent of and the advancement in retinal surgery, is we have to start thinking, could we give these people a refractive outcome that gives them really good vision and makes them more independent of glasses use? So what I would say is, in the earlier days, we would have been pushed a little more towards doing combined surgery, where we didn't really bother with anything but a monofocal lens. But now, when I talk to my cataract colleagues, they would tell me that we should be thinking to settle down the retina and then allow them to offer these patients, once that retina is good, and the option of having a refractive outcome type surgery. And this is something that, I have been thinking about, because we do so much cataract surgery now, whether or not we should be thinking about doing that later on. And I think that is where we would end up going with this type of surgery. And I think that's why we might move away from doing combined surgery with monofocal implants to doing retinal surgery first, just vitrectomy alone, and then come in a little bit later on and doing the lens implantation, either multifocal or some sort of refractive procedure.
Very interesting, very interesting. You're turning the retina around and asking us to think like refractive surgeons. And it's wonderful that you're thinking beyond just the retina, Dr. Bola. I'm very impressed because it's a very important point, because patients' expectations are continuously changing. And being mindful of that and to take things forward is very, very nice to hear. Dr. Dwarka, any comments?
So thank you very much, Retinal. This fantastic presentation. I fully echo the sentiments that were expressed before. And some of these cases do represent a challenge in whether we should intervene or not. The instinctive thing in a lot of ways from the surgeon's point of view is to intervene, but we always have to be mindful of not taking the patient out of a comfortable position and putting them into one that could be challenging for them. But at the same time, we also have to understand that surgically we're advancing, and surgical and retina is coming further, as well as cataract surgery, and the type of quality we could offer. So we have to bear in mind that sometimes intervention earlier is required because of the increased quality and assurance of outcomes that we can get from earlier intervention. And we're now basically increasing our skill level, having an increased quality in terms of the output. So moving towards a high-end surgical output in all cases is probably a reasonable thing to consider in the appropriate situation, rather than being conservative throughout across the board.
Wonderful. See, Renelle, you've actually got the retinal surgeons to think differently. Congratulations. Well done. It is nice to hear the slight variations, because I think as retinal surgeons, people forget that there is the opportunity to do refractive surgery in the appropriate case to bear in mind. It's nice to see so many comments. Please keep them flowing. Well done to Renelle, and I get Ibrahim to get his presentation up, if that's okay. I'll get Renelle to relax a little bit and get ready with her questions. Ibrahim, it's a pleasure to introduce you. I have known you for a long time now. I'm working along with CVRS and TEH. I know that you have graduated in 2017, and you have been working with CVRS and Dr. Bola and the rest of the team. I've always found you very enthusiastic and always very patient-centered with regards to your care. And I very much like that. And in my discussions with you, your interest in community projects, low visual aids, myopia management always enthuses me to see that how much you care for your patients. So it's a privilege to work with you, and please continue doing what you're doing. Would be lovely to listen to what you have to present to us.
Thank you, Dr. Kumar. Good night, everyone. Tonight I'll be presenting a case I found to be particularly tricky and interesting. So we'll start with the case history. A 50-year-old patient came into our clinic for a second opinion after being referred by an optometrist for posterior inflammation in both eyes. The patient was first seen by myself and then sent to see Dr. Bola. Her last eye exam was 2 weeks ago, and current spectacles was 1 year old. She had no significant medical history, including no diabetes, no hypertension, and no autoimmune disorders. She also had no significant ocular history, as well as no family history of glaucoma. She wasn't on any current medication and had no known allergies. Preliminary testing. The patient's unaided visual acuity was found to be hand movements in each of her eyes. The aided visual acuity was found to be 20/60 in the right eye and 20/50 in the left. Her pinhole vision showed a reduction in her visual acuity to 21/25 in each of her eyes. Her IOPs were within normal limits, 12 in each eye, and she showed no RAPDs on pupil testing. A refraction was performed where she was found to be minus 3.75 sphere with a best corrected visual acuity of 20/50 in the right eye. In the left, she was found to be minus 3.75 by minus 0.25 with a best corrected visual acuity of 20/40. Her AD was 1.75 with a near acuity of N8. Moving on to the next slide, we have the fundus appearance of the right eye. Starting with the left, we have the color fundus photo, where we can see a cup to this ratio of around 0.7 and an area of peripapillary atrophy temporal to the disc. Arterioles and venues leaving the disc have normal color, sheen, and course. No abnormal macular changes can really be seen. Even when we look at the red free on the right, we also see basically a normal fovea with no apparent abnormalities. Moving on to the left eye, the left fundus photo was quite unremarkable. Similar to the right eye, a cup-to-this ratio of 0.7 with peripapillary atrophy similar as seen in the right. No other abnormalities were really seen. At this point, the patient's file was reviewed by Dr. Bola, and he recommended we have an OCT macula done. Over here, we can see the OCT macula that was done. It's basically two different reports. The left picture is the retina map, and the right picture is the cross line. We'll start with the right eye. It's clearly that the patient had central foveal swelling, which can be depicted by the green arrow, a stage 1 macular hole, which can be depicted by the red arrow, and a posterior vitreous detachment, which can be depicted by the blue arrow. I'll zoom in so you can get a better look at the scan. When we look at the right retina map, we can see a red area of elevation, which corresponds with the central foveal swelling seen on the OCT. On the left eye, we can see depicted by the yellow arrow, the patient had VMT, or vitreomacular traction. However, the retinal map showed the patient had normal macular thickness. So far, while I was examining this patient, I found two main challenges. The first challenge was that it was difficult to assess this patient's fundus undilated via ophthalmoscopy. However, by using the fundus camera and OCT angio that was available, it made the imaging of the retina much more simple. And the second was lack of experience in dealing with these type of retinal pathologies. Shared care definitely made this case easier to handle, knowing an ophthalmologist was standing by ready to assist. The patient was sent to see Dr. Bola for an assessment, where he concluded the patient had central fovea swelling in the right eye and vitreomacular traction in the left. His plan at this time was to perform a fundus fluorescein angiogram to rule out inflammatory cystoid macular edema and also a glaucoma assessment. At this point in time, our differential diagnosis for this patient included cystoid macular edema, vitreomacular traction, macular hole, or macular telangiectasia. So how do we confirm our diagnosis? The answer is fluorescein angiography. Fluorescein angiography is a diagnostic procedure that uses a fundus camera to record the blood flow in the retina. As dye passes through the blood vessels of the eye, photographs are taken to record the blood flow. This process usually takes 10 to 20 minutes. The photographs can reveal abnormal blood vessels or damage to the lining underneath the retina. Interpretation of the abnormal angiogram relies on the identification of areas that exhibit darkness, brightness, also known as hypofluorescence or hyperfluorescence. So this slide here shows the FFA of the right eye. Starting with the left side, we have an autofluorescence photo where we can notice a hyperfluorescent spot seen within the macula. I'll zoom in so you can get a better look. No other abnormal findings were seen. The right photo shows the venous stage of the angiogram. The retinal vasculature looks pretty normal and intact. If we look closely, depicted by the small orange arrow, we can see a central area of pooling. It is barely noticeable. However, this area of pooling correlates with the spot on the autofluorescence photo and swelling as seen in the macular OCT. No other abnormalities were seen. This slide here shows the fluorescein angiography of the left eye. It's pretty unremarkable. Here we can just appreciate a standard angiogram with no relative or no abnormal findings. After the doctor reviewed this fluorescein angiogram, the following diagnosis was made. The right eye had a posterior vitreous detachment, over a cyst in the area of the fovea. No vasculitis or papillonitis seen, so not suggestive of a cystoid macular edema. The right eye likely had a stage 1 macular hole, which was currently resolving. And in the left eye, the diagnosis was made that the patient had left vitreomacular traction. Just to note, there are two types of macular holes that can spontaneously resolve on its own. The first being a stage 1 hole, and the second being a traumatic macular hole. In this case, the patient had a stage 1 macular hole, so we decided to closely observe this patient. The patient was educated about her condition, and a 1-month follow-up was booked with the doctor. The patient returned in around a month's time for her follow-up visit, where we repeated the OCT scan. In the right eye, which is the left photo, we can see there is still foveal swelling. However, as depicted by the yellow arrow, we can see that there was a resolution of the macular hole. Over to the left eye, we can see a successful vitreous detachment as depicted from the red arrow. At this point in time, we spoke to the patient so that she understood there was a spontaneous closure of a macular hole. The patient was advised that her vitreous detachment is ongoing, and if she experienced any new floaters or flashing lights, to please return. An AMSA chart was also provided. An appointment was given in about 4 months for review. So the patient missed a few of her follow-up visits, and she returned approximately 11 months after. The OCT was repeated, so now we are able to see what we call a retinal map change analysis, right? Starting from the left, we can see the first scan that was done on November 2017, followed by the middle scan, which was done a month after, and then the scan all the way down to the end of the year on the right-hand side. We can see that the central foveal swelling slowly but surely went away. Looking at the retina map, there was a reduction of around 110 microns. And the foveal thickness graph also showed a slow but surely reduction in the foveal swelling. The left eye, in terms of thickness, remained relatively stable over time. At this point, no follow-up visit was needed. The patient was advised to go ahead and do a refraction and proceed with her spectacles. Using this case as an example, I found shared care to be pretty useful in managing this patient. Some benefits of shared care include access to advanced imaging equipment that may not always be available in optical practices, including the AOCT angio and fundus camera. Patients can also be seen almost immediately based on urgency due to a direct line of communication to ophthalmologists. Optometrists are also able to follow through with patient care until the patient can return after for spectacles. In conclusion, stage 1 macular holes and traumatic macular holes can spontaneously resolve on its own. However, it requires close observation. And secondly, shared care between eye care professionals should be considered the new norm. It leads to it's cost-effective towards the patient. It leads to a higher quality of patient care and satisfaction, and increased access to healthcare services. So that's it for my presentation. We'll open up the panel for discussion and questions.
Wonderful. Thank you very much, Ibrahim. Wonderful. Can you just bring back the slide with progression analysis, please, while I bring Dr. Bola and Dr. Dwarka into the conversation? I'll start off with Dr. Dwarka. Dr. Dwarka, your thoughts?
Thank you very much, Ibrahim. This was a fantastic presentation, as usual. This particular case in the resolution is one of these examples that you really wish that you see, because it's in the natural progression of things, we don't always come across resolution like this. We know theoretically it does, and sometimes when we explain to the patients, we say, in a certain percentage, it spontaneously resolves. But in this particular case, we're able to see the diagnosis being made, the imaging modalities showing the different points in the subtle points in the diagnosis, and we're able to see the actual morphological changes in the OCT representation. So I think this is an excellent case that we've been able to identify.
Thank you, Dr. Dwarka. And Dr. Bola?
Well, I have to be honest, I have never seen this before. You know, this is such a great follow-up of a full thickness macular hole closing without intervention. So it is probably a little bit of a reportable case for Ibrahim. I really like the case. I think he's brought home some other points other than the stage 1 hole can close without intervention, about the shared care part of it. I think when I saw it, I would have thought that cystic area was interesting, and I couldn't really explain why you had that roof to the hole, and that's why I was thinking, hey, we better make sure there isn't any other pathology going on, because this is so odd to see. So, but very nice case, Ibrahim. Well done, well presented.
Thank you.
Yeah, it is. As you rightly pointed out, Dr. Bola, it is challenge sometimes to know what else pathologies might be going on. And I think I agree with Ibrahim that it really helps in using the modalities that we use in our clinical practice to understand the retina better and the macula better, always examining the periphery and making sure everything else is going on fine. But what was interesting for me is I have seen a few traumatic macular holes resolve, but invariably as a retinal surgeon, the urge is to intervene. This is, as you rightly pointed out, a phenomenal case to see progressive analysis of closure, and also having a conversation with the patient that this can get worse, and if it does, we would operate. And that is why you have to keep the patient involved all the time and give them the right education. I'm going to just bring in Dr. Boehringer to give me your thoughts on this kind of an interesting case. Any thoughts you have?
No, I think basically is what we teach the students. You know, when you have a grade 1 macular hole, you don't do anything. You just watch, you just monitor, and see how the progression, because a lot of these grade 1 tend to resolve on their own. So no rush, you know, just as long as you're ready to monitor closely, you can just, you don't have to, basically, don't have to refer, just watch very closely.
Thank you, Dr. Boehringer.
Yeah,
that was very useful actually, because we keep going back to the basics and say that important to involve your patient in all your conversations. My take-home message to anyone is imaging is something very powerful. Please show your patients what is going on with their eyes using the images that you take as a tool, and get them to buy in as an ownership of their imaging, because that way you have partnership built up with your patients. And then how do you monitor and how do they seek help is the way forward, and giving them the appropriate information. And that is something that I would recommend everyone to participate in with every patient that you'll see. You'll do a phenomenal job, but we want to keep continuing this as we go along. Ibrahim, thank you very much. Now we've got Dr. Boehringer, who's going to share some of his experience with us, and while he gets his presentation ready. And it gives me great privilege to talk a few words about Dr. Boehringer, although I don't think I have done enough to interacting with him in person a lot. I know Dr. Bola has interacted with him a lot more than I do. He's no stranger to all of y'all. And Anura provided me information about Dr. Boehringer. And I read through all that information and I kept staring at the information provided. I said, wow, what a phenomenal journey it has been about being a student all through your life. It is indeed a pleasure, Dr. Boehringer, for you to share your time with us and continue to educate us. And I am particularly inspired by your enthusiasm on the WhatsApp group, because you're probably one of the first ones to answer to most of the queries put on to by Vikash. And I understand that you've been in optometry since 1997 because you lived a different life before that. And that conversation is for another day. So thank you for your time and thank you for continuing to educate us. The floor is yours, sir.
Can you all hear me? Or?
Yes, Dr. Boehringer.
Okay, yeah, fine, because I'm not seeing the unmute. So thank you very much, Dr. Kumar, and also Dr. Bola, Dr. Dwarka, for having me on your platform. Greetings to all the attendees, and of course, a very special hello to the students as well as the former students. I hope this very, very small contribution presentation that I'm going to show will inspire some of the students to bring their own as well. It seems the whole topic of this evening seems to be the macula, really, because I also have a case on maculopathy here, right here to present. I must say that I haven't seen the patient at all. What happened, the story is that the student who's, I hope, attending here, because if I make any faults, she should correct me. Sarita Dean is her name. She saw the patient together with her supervisor, and she showed me the OCT pictures afterwards. And looking at the OCT pictures, right away it clicked in me. Sometimes you have to be careful about this instantaneous click, because I've seen this. I look at it and I say, I've seen that before, So, I kind of a little rush to the conclusion, but so I'm glad for the ophthalmologist to give a second opinion, or please, if you disagree, do so, don't hesitate. So let's come to the case that is under discussion here. So we have, did the PowerPoint based on the notes of the students. So we have a 61-year-old female on African descent or Afro-Caribbean descent, presented to UE for a general eye exam. She didn't really have any special complaints. First eye exam at this age, and in fact she didn't do the what they call the appointment herself. Her niece decided to bring her together with I think it's brother, to the clinic and just have a full eye exam. So first eye exam. All right, I'm just going to go quickly over the history, the optical, the health, and so on. She's using a pair of plus 350 readers, so she doesn't use anything for her distance vision, just for the reading part. That's it. But upon probing by the student, the supervisor, she mentioned there's a cloud. She calls it a cloud that comes on her left eye when reading, causing a double vision. So like something like I'm reading on the record, up and down diplopia. So this is the first part. And she said she was seeing blurry her left eye a long time. Apparently it really, she noticed that when she was more reading. She had no complaint about the vision the right time, and the distance vision, she had no complaint also is good. And it was like that a long time. Again, first eye exam, family was here. Everything organized by her niece. I think the whole family from Siparia, I think, Sarita, if I do any mistakes, please correct me. So no ocular history, basically, only the occasional strain at near. I went to see an herbalist in 2020, was told that the blood was thin, uses Advil for arthritic pain, family history, positive for cancer. Okay. Now this is a history part, so nothing really absolutely unusual except that cloud on her left eye. So preliminaries, no problems there, especially no APD. Okay, so we do an APD, no APD. Right. So the unaided VAs were 2060 and the pinhole was 2030 on the right. And looking at the left eye, 2080 minus. And with pinhole, not seeing anything. OU 2060, but again, she had really no complaint about the distance vision. All right, so basically the lensometry, 350/50 readers, near vision, and the subjective refraction was right eye 125 with 20/20 on the, so with plus 125 sphere, she achieves 20/20 on the right eye. On the left eye with plus 150, she achieves 20/30 minus, okay? And we've corrected, fully corrected, with both eyes looking, she sees 20/20. So good vision at distance with both eyes together. Right, so looking at now at the health, primary care, there's some early lens changes in both lenses, but just early, nothing really drastic. She has some staining inferiorly on the cornea. Again, nothing drastic, central cornea is clear. So basically the whole media is clear, right? Looking at that, whole media is clear. All right, so now we're going to look at the back of the eye, and we start with the right eye here. Unfortunately, we don't have all the nice equipment, Dr. Bola, but still we try to do our best with what we have. So this is the posterior pole of the right eye here. There's a little, like a little cloud here. I think this is due to some, that's an artifact, I think, due to the lens of the OCT. And this is a red 3 here. So I can't really see anything to mention looking at the fundus here, just a little bit of vertical elongations here. So really looking at the pictures, they really pay too much attention to that. And this is an OCT here. Unfortunately, it's a bit small here, but looking at the pictures here, you don't really see any problems. Macula looks as it should be, typical V here. The thickness looks okay as well. So everything going okay here. Now looking at the left eye, when you look at this from a distance, okay, here you're looking at here, but if you were looking at with your indirect UBIO, you see the lady has 2 optic discs. That's why she's seeing double. Anyway, just looking. So you're seeing the macula brings your attention straight to the macula, and you see like a yellow and large spot on the macula, and next to the, I don't know if you can see my pointer here. I'm not sure.
Yes.
Okay, but around the fovea here, you see this atrophic piece of atrophic retina, concentric to the fovea here. So I'm sure it rings a bell by a lot of the attendees, and definitely among the ophthalmologists. Well, it rings definitely a bell in me, and say, ah, I've seen that before. Now looking at the OCT now, and you see this, there's what they call a something looking like a little something that pushing up the macula forward from the choroid. And the first thing you would, if you didn't see that yellow spot, you would think it's a near choroidal neovascular membrane. So these are some views here, but basically the retina is just pushed forward, but there's no, I mean, the tissues are not really disorganized. Like a CNVM, you see everything is totally disorganized, destroyed, but it's just pushed forward here. So let's come to the different diagnosis here. So that's what I, first of all, right away, it clicked, and that's what I would have thought here, vitelliform macular dystrophy. Here, that's the differential. In our case, would be an adult onset, okay? But you have two types of vitelliform macular dystrophy, two types of adult onset macular dystrophy here. And then, of course, we have the ARMD, wet ARMD, with choroidal neovascular membrane, definitely, which is present. Now, digging a little bit into the subject of vitelliform macular disease now. It's an autosomal dominant disease, and you have two clinical variants. The one what they call which people are more familiar with is the Best disease, okay, which usually occurs in boys, right, teenage boys. But you have also an adult onset of vitelliform macular dystrophy. And the genes, of course, you know, in these dystrophies, you have always to bring in the genetics. And the typical Best disease has the mutation in the VDM2 gene for early onset, and to some part also adult onset here. You have also, among the adult onset, you have mutation in the PRPH2 for AOV-MD, which is adult onset vitelliform macular dystrophy. So Best disease usually diagnosed during childhood, adolescence, can also have late onset, which makes it difficult to distinguish. I mean, we're not too sure what type it is. Usually bilateral, but can also occur unilaterally here. So vitelliform macular disease, normally the normal the development in time is a bright yellow cyst, or some people like to call it a fried egg, you know, and the cysts eventually will rupture, creating the appearance of a scrambled egg. So you get a fried egg going into a scrambled egg here. Once the cyst ruptures, the macula and the RP begin to atrophy, and central vision reduces, and periphery remains unaffected. Yeah. Right. So adult onset lacks, if in case of the adult onset, it lacks the typical cause seen in Best disease here. Right. And then, of course, second differential, you have always the wet ARMD with a choroidal neovascularization membrane, which is rapidly progressive, causing scarring and destroying central vision. I mean, of course, you have to be aware that a complication of the vitelliform macular dystrophy is choroidal neovascular membrane. So what are you going to do next? What are you going to do next? So in case with Best disease or even adult onset as well, the first thing is doing an electrodiagnostic testing, which is an electrooculogram. I know before, maybe it might be different today now. Before, the positive EOG was pretty much pathognomic for Best disease. That's for the classic Best disease here. Now the adult onset disease can, looking at the literature, can also have a reduced EOG, but not always. So when looking at, I'm not going to go into a presentation of the electrooculogram, but basically what you look at is the Arden ratio in the EOG here. You should do an OCT angio, of course, that needs to be done. It gives information on the presence of neovascular vessel, maybe combined with a fluorescein angiogram. And genetics, Indian genetics to establish presence mutation. When it comes to genetics, not too sure how to go about this here. So my provisional diagnostic is adult onset vitelliform macular disease. And the way I'm going to go about it is do, first of all, the OCT or the FA, depending on the patient. I mean, this patient was difficult to contact here. I think the student finally reached her, but they're not too sure she's very amenable to further follow-ups on this, but we try our possible here. So first we do a FA OCT and fluorescein angiogram, and if this is negative, then we'll do a EOG. But the OCT A is first. And this concludes my presentation here. I'm sure there'll be a lot of discussion.
Yeah, thank you very much. Thank you very much. That's a very interesting case that you have presented to us. Would you be kind enough to just show me some of the OCTs, particularly the left one, while I bring Dr. Dwarka into the consultation, discussion out here?
Yeah.
So, yeah, that's fine. We'll just go to the left one, yeah. Dr. Dwarka.
Hi, Dr. Kumar. Dr. Beringer, fantastic presentation. I really appreciated it. It's not something that I would say that we all basically aware of the presence of BEST, and we are aware of the presence of these vitelliform type issues, but it's not often that we see them as well prescribed as this, and it was quite useful as you went through the stages. It's basically what comes to mind very readily is, as you described, the use of the EOG in diagnosing BEST, and it's not something I've had enough experience with, but I appreciate the case. Thank you.
Thank you, Dr. Dwarka. Dr. Bola, are you there? He's just gone out to get some water, so I'll just wait for him to come back. I used to see some of these cases in the UK a lot more than in Trinidad. And as Dr. Boehringer pointed out, they tend to be a coincidental finding in large number of patients. And it is very, very interesting as to how perplexing they can be. And I think Dr. Boehringer has pointed out to us the two confounding factors is this wet macular degeneration? Do I need to treat? Or is this adult vitelliform dystrophy? And how do I manage this? So I think he's put the case forward very well. And I don't know if Dr. Bola is back. Yeah, he's back on. Dr. Bola, have you seen adult vitelliform dystrophy cases?
Yeah. What's interesting here, Vin, is that the vision is so good in this eye. You know, when you look at that lesion, you would think that the vision should be much worse. So that's interesting with this type of dystrophy, that when they do present, although they looked, pretty startling, pretty bad, the vision could be pretty good. The other good thing about this type of, this adult best is that they usually will maintain pretty good vision over time. So, that's pretty interesting. The interesting thing is you could look at it and think, is this a big drusen?
Yes.
So that's another point,
Yes.
And they too do very well. They don't have the sliding reduction in vision like normal type AMD cases would have over time. So it's an interesting case. I didn't catch what the EOG and stuff showed. Did it pick up Best disease and diagnose it, or was it?
No, well, we didn't do any EOG. That's one thing we want to do.
Okay.
I thought we should first do the OCT angiogram, and then if everything is okay, then do the EOG. But again, our clinic closed,
Right.
The clinic is closed, and this patient was difficult to contact elsewhere. Yeah.
There's some very useful things, Dr. Boehringer, that you've pointed out in this particular case, and also the color pictures. One thing I picked up is the right eye did not show any drusenoid deposits in the macula. So that's a good point to pick up. That's the first thing. The second thing is in the left eye, there is no drusen around the fovea except in that central area, which Dr. Bola has pointed out may look like a large drusen. So that's a very important point to wonder whether there is macular degeneration coexisting, because it can coexist. It's not that it's impossible not to coexist. And when it coexists, the challenge is whether there is a wet macular degeneration on top of the vitelliform dystrophy. And as you rightly pointed out through the OCT, the retinal layers appear to be intact. There is no fluid. There is no subretinal changes apart from the elevation that was noted. And that is a very good, useful finding to use to monitor this group of patients, because it's going through a disruptive phase at this point of time with RP changes that you see out there. And I think Dr. Bola also pointed out the fact that these patients tend to maintain very good vision long term. And it's only over a period of time that they notice the gradual reduction, particularly with near vision rather than distance vision. And because we are blessed with two eyes, they tend to seem to overcome this problem unless they shut the good eye. Then they find to have problems. But an excellent case. It's good to be aware of what's going on at the back of the eyes and identifying what are the differentials, looking at various other things that might be going on, and deciding what's the route of investigating this patient. But an important thing that you pointed out was genetic counseling. I think it's a very valid point, particularly in somebody who has this problem identified in very early age because it has implications for their children going forward. So that's where I have been involved through the geneticist in doing genetic counseling for these patients. Because I am, as an ophthalmologist, don't get into it, but we use the geneticist, particularly in the UK when we had these kind of macular dystrophies that presented to us. So Dr. Boringa, thank you very much for sharing this wonderful case with us.
You're welcome.
Yeah, thank you.
Just a quick comment
Yeah.
before you move on. When you see lumps like this at the posterior pole area, not only in the macula, you have to think of whether it's like an osteoma as well arising out of the choroid. So a good idea is to look at it over time and also do a B scan so you could measure the thickness of the lesion. It's just something to think about too. The other thing to think about, but this doesn't really look like one, but whether it's a primary or a secondary, you know, of these emelanotic lesions. So it also you also have to think along those lines. The other reason you have to do that is because the right eye, this one is the left. Yeah, the right eye didn't really show a lot of change. I mean, there was some subtle change, and best is usually bilateral. So it's a very asymmetrical looking lesion. Very interesting.
Good point. Yeah, very good point. And I think there's one question I'm going to address from the chat is Nikisha has asked a question. Question with regards to investigation into the genetic mutation aspect of the case. I don't know if I remember correctly, but would the family history of cancer be a good place to start? Dr. Boringa, any comments?
Absolutely, yeah, for sure.
Yeah,
Again, I can answer that now because clinic is closed, so nothing much I can do about that. But definitely, of course, yeah.
Yeah, but is there any cancers that related to Best disease at all? Any associations that you have come across in your literature reading?
Say that again, please.
With Best disease, is there any cancer associated? Any history of cancer? I have not come across anything particular.
No, I don't know anything about that. No, not to me.
No.
I mean, cancer was just happened to be there, but I'm not seeing any association with that. At least I don't know about it.
Okay. So I hope, Nikisha, that we answer that question. Yeah.
Okay. Yeah.
You have to look for things like breast and lung. Those would be the two areas. Yeah.
Okay. But still, something to think about for sure. Yeah.
Absolutely. And I think Dr. Bola pointed out that if you see a lump in the back of the eyes, you have to start thinking of whether there is a secondary lesion. And we as ophthalmologists have seen these things presenting, to be honest with you, as difficulty with reading. I vividly remember some cases that had presented with that problem. And when we looked into it, they were secondaries from breast cancer in the past. And Dr. Bola and myself worked in Sheffield, where we worked in an ocular oncology center, and we used to see a lot of pathology at the back of the eyes, and always used to think of cancer related to the eyes. So yes, it's a very good point you brought out, Nikisha. Thank you very much for that.
Yeah.
Right. Thank you for all the presentations. Very interesting, and I'm so happy to see the amount of discussion that has happened. And I'm going to bring in my colleague, my friend, Dr. Bola, to do his talk. I don't need to introduce him to you all. You all know about him. The only background that you all need to know is that we both trained together way back in Sheffield. I won't tell you when. And we have been practicing as consultants, him back here in Trinidad and me in the UK. So he's been back in Trinidad and working out here for the last 10 to 12 years. So he's going to share his experience in the management of vitreomacular interface, and then we would have a conversation and discuss between the panel at the end of it. Dr. Bola, the floor is yours. Thank you very much.
You can see my screen, Vin?
Yeah, I can see your slides.
Okay, and you can hear me, right?
Yes, I can. Yeah.
So everything looks okay. So tonight I'll talk about the vitreomacular interface and the type of diseases we see. Now, the interesting thing with this meeting is that I was preceded by some excellent presentations and excellent presenters, and I feel under pressure now for doing this talk because these guys have done so well. The other thing is a lot of stuff that was spoken about really helps with this presentation a lot. So I want to thank the previous presenters, not only for giving excellent presentations, but also really contributing to the discussion on VM diseases or vitreomacular interface diseases. So the vitreomacular interface, this particular talk, I'm going to go through 5, and at the end of it, I would expect everybody to be able to identify and diagnose all the different types of vitreomacular interface disease by just using clinical findings, OCT findings, as to be able to figure out what it is and be able to know what to do with it as well. The other thing I would try and cover in this talk is some of the new treatments, things like octoplasmin, things like injection of gas like SF6, C3F8, and also still talk about the more conventional surgeries for VMT and some of the newer surgeries for vitreomacular interface disease. That includes VMT, that includes macular hole treatment. So we start with just talking about a little bit about definition. When I think of VMA and VMT, really the only difference is traction here. One is adhesion, which is the A, the VMA, and the other one is traction, VMT. So if you just remember that, you remember the difference between these two retinal interface diseases. And this is a nice cross-sectional image to show the VMA, which is the whole of the posterior cortex of the vitreous plastered onto the macula itself, as opposed to the VMT, where there is a tractional component because of the AP traction exerted by the detaching vitreous as it tries to pull away from the retina. Well, this is just a slide to show this that you could stage VMT like this in a stage 1 or a grade 1 to grade 3, where you have increasing levels of traction. Now, I don't particularly like this classification. I more prefer one of these. And the one that I would want you to remember is just whether or not the VMT is focal or broad. That is, remember 1500 microns, because that's the key to everything. 1500 microns, if it's less than that, it's called focal. And if it's more than that, it's called broad. And that's what a lot of vitreoretinal surgeons use. That's what a lot of the studies would use. As we move on, we'll talk about that. So this is a clinical example of a case we had in the clinic of a nice example of a broad-based, a really wide area of traction. The little yellow arrow shows that there is a sort of double pathology here. A little ERM is also present with the VMT. And these cases do really well with surgery because we could restore the retinal architecture almost back to normal and really cure the metamorphopsia. The next type of vitreomacular interface disease is the ERM. And really, I can't really say much more than what Renel did on ERMs because it was so well put together, those cases. But I'll just explain a little bit in general when we think about ERMs. You know, when you have no reduced vision, no metamorphopsia, good VA, and minimal retinal change, as you see here in this ERM on OCT, just like Renel said, we tend not to think about doing anything because these remain really stable over time and there's not much change in visual acuity. So I don't usually follow these very closely, maybe once a year, once every 6 months, but not that much. In general, we tend to do surgery when the OCT shows change in the foveal architecture, as you see in these ERMs, which cause a lot of distortion in the foveal and macular architecture. And these usually produce metamorphopsia. And when they have metamorphopsia, they tend to do well with surgery. Overall, vision improves only in about 60% of patients who have ERMs, and the rest, which is 20%, about the same. And sometimes even when you remove the ERM, they still might get a little worse. So you have to be careful how you counsel these patients when you want to do surgery in ERMs. The next vitreomacular interface disease, just to touch on, is the lamellar hole. And this one usually forms after the ERM sits on the retina for a long period of time. So it's usually a sign of chronicity of an epiretinal membrane, where you have the intraretinal cysts, they coalesce and they form a defect in the retina, as you see in these OCTs. These don't do that well with surgery. There's not much improvement in vision. So we usually don't really recommend surgery for lamellar holes. The good news is lamellar holes don't usually get worse with time. So you just tell the patients, this is likely to remain pretty stable over the next few years. So don't worry too much. The other bit of good news is lamellar holes usually didn't have poor vision. They usually have slightly reduced vision, 20/40, 20/60 at worst. And they usually remain with that for life. The last one of the lot is the macular hole. And this sometimes could be difficult to recognize unless you really pay really close attention to the fovea. And you really need a well-dilated pupil to have a good look at the fovea to pick these up. And what you will notice on really good foveal or macular biomicroscopy, as these photos show, is you'll see a cuff of subretinal fluid, as you see in here, around the whole edge. And then at the base of the hole, you'll see these yellow deposits, and that is typical of a macular hole. I don't really like this slide too much because it's so busy, but it's a really classic slide that has to be shown when you think of macular holes, because it's Don Gass, one of the icons of macular surgery and macular holes, and his classification was done pre-OCT. And the interesting thing is, when we got OCT, we were just confirming what Don Gass had written 40 years ago about macular holes. The stage 1 hole, which Ibrahim talked about so nicely and depicted so well on OCT, in his case, really presents clinically with just a little bit of a yellow dot, and OCT shows that there is not a full thickness break within the retina, but just a partial break in the deeper layers. And in stage 2 holes, you have now a full thickness break within the retina, and the vitreous is still attached. But these holes are in small holes at stage 2. When they get a little bit bigger and they cross the 400 micron size, then you call them a stage 3. And when you get a vitreous detachment, then you call it a stage 4 hole. And prognosis really changes a lot as you get from stage 1 to stage 4, as you see here in this slide when you look at prognosis. Let's move on now and talk about treatment options for vitreomacular interface disease. I think you really only have 3 options with these, which is good to know. The less you have when you're a retina surgeon, the better. So either you're going to observe the thing, which is no intervention, you're going to inject something in the eye, or you're going to do a vitrectomy. So that's really the only options we kind of think about when we think about these diseases. And one of the treatment options is the injection of a drug called ochraplasmin. So ochraplasmin is a recombinant truncated form of human plasmin, and it is vitreolytic. It basically breaks the bond between the ILM and the vitreous, the posterior hyaloid face, or the vitreous cortex, and causes a PVD to be induced. So that's the kind of principles of the ochraplasmin. Ochraplasmin got FDA approval using 3 studies, and those studies were the MIVI studies, as you see here, 2009, 2010, and 2011. In combination, these studies amounted to 652 patients, so it was quite a big number, and they were able to have a placebo group which got no or sham injection, and then the ochraplasmin group which got the ochraplasmin injection. And they were able to show that ochraplasmin was highly effective at, as opposed to placebo, with a really high p-value in the vitreomacular traction resolution type of cases, and also in macular holes. That is the early stages, like stage 2 macular holes, 40.6% as opposed to placebo, which was 10.6%. So based on that, they got FDA approval to be used in certain conditions. And this was the type of conditions which it was approved to be used in. VMT, vitreomacular traction, which was symptomatic, and less than 1500 microns, which is the focal type. So you had to have that, or a stage 2 full thickness macular hole, which is a small macular hole of less than 400 microns. And you can't have any other pathology, such as an epiretinal membrane. So these are the type of cases we would consider ochraplasmin in. If you will look at the other side of the coin, what type of cases you wouldn't consider ochraplasmin in? Well, if you see an epiretinal membrane present, or if you see a large macular hole, then you really wouldn't be thinking about ochraplasmin. Ochraplasmin is not without its problems and complications. You can develop retinal tears and possibly retinal detachment as a result of a retinal tear if you miss it. And you could develop other symptoms, as you see on this list. All these symptoms, except dyschromatopsia, is intermittent. So you could reassure patients that they're likely to just go away, and it's really not a big deal. The other thing is the incidence of major complications like retinal tears is very low, less than 1%. So in general, oculoplasmin is relatively safe to use for this condition. The most disturbing problem is the dyschromatopsia, which is a color vision issue that develops after the injection. And they're not sure exactly why and why it might persist. So that's one of the few things you have to warn the patient that might occur before you think about injecting. The weakening of the zonular fibers and possibly lens subluxation doesn't seem to be a big issue, as was first thought. It really is more one of academic interest. So if we look at pros and cons of using the oculoplasmin and why it was so attractive in the beginning, well, we were very attracted to oculoplasmin because, as you know, when we do macular hole surgery, we have to use a gas bubble and we have to posture the patients. And that could be very annoying and very difficult for some patients. If we could have just injected something in the eye in the clinic, well, that would be great because we would save the patient from having to have a bubble and posturing. However, the cons really led us initially to want to try oculoplasmin, but later on to decide, well, this doesn't sound like a good idea. And the reason for that was surgery has such a much higher success rate than oculoplasmin for early macular holes. You know, it's really more up like 95% and more surgery compared to 40% with oculoplasmin. And even VMT is extremely high success rates with surgery versus a low success rate with oculoplasmin. And the cost really is the big problem here, where the drug itself costs you $4,000 US, and surgery is actually cheaper to do. So if you did inject oculoplasmin and 75% of people, the VMT didn't go away, you end up having to operate on 75% of patients you injected, and then they have to bear a cost of $3,000 US after that. So it really wasn't becoming an attractive offer in practice. So some guys decided, well, let's inject something else in the eye. You know, the retina guys are kind of mad, and they decided to inject gas in the eye and see what happened. And this is what happened. They inject gas into patients who had VMTs, and they noticed that they did better than the oculoplasmin. And the cost of gas to inject into the eye was cheap. So they decided, wow, well, let's inject people, you know, with gas and see what happened, because it is a better option. And what they realized was 44% or so of full thickness macular holes stage 2 closed, and 48% of VMTs kind of resolved. So it started to become the go-to thing now for VR guys to do. However, it doesn't seem to work in stage 3 and 4 macular holes, and there is a risk that you could detach the retina, especially in myopic eyes. So we started to think, maybe we should go back to surgery and stick to what we know. The interesting thing is, in Trinidad, most of our holes present late, stage 3, stage 4, so we tend to go to surgery as the go-to thing still, even though gas injection is an option now that we can consider, and because it's a in-clinic procedure. So let's talk a little bit about, you know, what is the conventional treatment for it, which is vitrectomy with gas injection. For VMT and stage 2 full thickness macular hole, when we look at our results in TEH, CVRS, it's over 95% success rate, surgical success, and really a very low risk of retinal complications with these early presentations of macular hole and VMTs. And most cases, unfortunately, most cases of macular holes still present us pretty late, stage 3 and 4. So we still really only use other modalities very rarely. So back to this case that I started off with, which is a case of a VMT, broad-based VMT with an ERM. And because it's broad-based, greater than 1500 microns, it's not really amenable to conventional, oculoplasma in one of the newer treatment modalities or gas injection. I think you have to do surgery. And this case we took to theater. I did combined surgery. I removed the cataract, put the lens in. And then, as Renelle said, I did what's called a triple peel here, where I used first triamcinolone. The hyaloid was obviously attached, and we gently removing the hyaloid or the posterior vitreous cortex off the optic disc, as you see there, just off the optic disc. And now we just around the macula fovea. So what we're doing now is doing a dissection around the fovea or around the macula. And we have to be really careful here because you could easily pull the macula or fovea into the cutter. We've stained now with a blue called membrane blue, and this is the epiretinal membrane being lifted off the macula. You could see it being taken off. It's a pretty huge epiretinal membrane that's been lifted off and removed. This is a third dye called brilliant blue, and now we're removing the ILM, the internal limiting membrane, off the macula here. And the reason we do this is to prevent recurrence of the epiretinal membranes. So this case was surgery for vitreomacular traction and an epiretinal membrane. Really, really nice case of surgery. And as we had in one of the slides previously, we showed the nice improvement in vision in this case. One of the interesting points here is that this case had disabling metamorphopsia and reduced vision for more than 2 years. And what's very interesting here is the resilience of the retina, especially the macular part of the retina, to detachment in this condition, which is vitreomacular traction, and how improvement can still be achieved even in chronic conditions or chronic vitreomacular traction type disease. This is what we call now conventional peeling, which we still do for most of the bigger macular holes, which is called also macular rhexis. And you can see why it's called macular rhexis. It's because we're removing the internal limiting membrane in a rhexis type approach, in a circular fashion around the fovea in a sort of disc pattern. And this is what we would term conventional ILM peeling. This is a newer technique that's been propagated a bit more for larger holes, such as stage 3 and stage 4 holes, because sometimes these holes don't want to close, and we really have to try and use more advanced techniques to try and close the macular hole. So here we inject in the brilliant blue again, and we raise in a little bit of the ILM with in this case, I use a little needle to cut the ILM. And then we use a little forceps now to raise the internal limiting membrane. And what we're going to do is produce a ILM flap. And that flap, we're going to bury this flap of ILM into the macular hole itself. So we're going to flap it into the hole. And what we are hoping is that this ILM would produce a scaffold for the migration of glial cells into the hole and result in macular hole closure. That's the kind of principle that we use. And we bring the air in, and then we usually replace that with a gas or gas injection. So that, in a nutshell, is this sort of treatment and the treatment options that we have at our disposal, bringing you up to date to the 2021 treatment of vitreomacular interface diseases that exist. And now I think we could diagnose each one easily just by using our clinical judgment OCT findings. And now we have a much better idea of the available treatment options that's out there to treat these conditions. I know we ran really late with this retina symposium, but I think it was a very exciting meeting with a lot of brilliant presentations. And I thank you all for keeping and staying with us through till the end. Thank you very much. Back to you, Vin.
Thank you, Dr. Bola. Actually, you are on time.
Oh.
You kept up to your time for your presentation, so excellent.
I hope I wasn't too quick.
No, you weren't. You weren't. I think we will find out if it's basically questions that are going to flow now. I'm looking forward to questions and comments. I'll bring in Dr. Dwarka to share his experience in managing vitreomacular interface problems while we wait for questions from our colleagues. Dr. Dwarka.
Thank you very much, Dr. Kumar. So, my experience has been very closely associated with TEH and Dr. Bola, and it was basically sort of mirrors that. The primary issue we have with interface problems, let's say, for example, ERM, would be whether or not to intervene. The basic skill, the first bit of skill is patient interaction, so that you be able to give them enough knowledge so that they can have an informed decision, because as the professional, you could slant it in any way and they'll have to believe you. So you've got to be able to note from the condition going on, which is the best way to slant the discussion, and to give enough information so that you could come up with the best possible solution for the patient. In terms of the surgical interventions for vitreomacular interface situations, quite rightly so, in terms of the options for us usually would be leaving alone or vitrectomy with manipulation of these membranes and the occurrent membranes and the ERM type things. Ochraplasmin is incredibly expensive. We've chatted about it many times. I've not found a logical way forward for it. We've considered gassing and all these other things independent of vitrectomies, but found that the success rates are so, compared to the surgical approach, is not as appetizing, I thought, because in most patients that I've had to deal with, looking at a success rate of about 44% as opposed to 80 to 90%, most of them feel that we should just get it over with if they're going to have it in the best possible way forward. And still, in terms of success rates, surgical intervention in terms of vitrectomy and manual peeling of these membranes seem to be the best option in terms of the highest success rates. So we feel all of the conditions identified, we've on more than one occasion have to deal with them, and we deal with them on a regular basis. And I should sort of like to underscore for everyone that we have options for these patients. And when we get them early enough, our options have higher success rates, and we'd sort of implore upon you to utilize us. And we are more than willing to lend our expertise and for the care of the patient and for the best outcome possible. Thank you.
Thank you, Dr. Dwarka. Thank you very much. Going through the questions in the chat, there are plenty of thank yous and excellent presentations to the speakers. One from Dr. Boringa. How do ERM initiate, and I was interested by the fact that removal of ILM prevents ERM from happening. Dr. Bola, do you want to pick up that question? How do epiretinal membranes initiate?
So good question. Usually, when the idiopathic ones develop, and that's the most common type, that's the one we see mostly, they develop because the posterior vitreous has detached from the retina and left a piece of the posterior hyaloid face on the retina. So it's actually the posterior hyaloid that you're looking at, a remnant or what's left behind after the PVD has occurred. And you have this piece of posterior vitreous. And what happens is you get migration of glial cells onto this piece of vitreous. And that's the majority of the idiopathic ones we see most of the times. There are other forms of ERMs or pathological types. The other more common or other common one is when you have a break in the retina and you get a retinal pigment epithelial cells migrating from the RPE through the break. It goes onto the macular area, and RPE cells could form any type of tissue. And what they do is they form a fibrous or glial type tissue on the retina in the macular area. And some people call that PVR, but if it really just forms a membrane, it will look exactly like an epiretinal membrane. And those are the two most common types. Now, why do we peel the ILM when we do an ERM? It's because an ERM can recur on the retinal surface. It is very rare, 1 in 100 ERMs recur. If you peel the ILM, the ERM is 1 in 1,000 or less chance that it could recur. So it's very, very rare to see an ERM recur when you do a double peel, an ERM peel combined with an ILM peel.
Thank you, Dr. Bola. I mean, yes, in my experience, that is exactly what we've seen, that if we include the ILM, sometimes they are integrated with the epiretinal membrane, they come out together, but repeating the assessment of the macula with the brilliant blue allows us to confirm if the internal limiting membrane is removed and reduces the risk of a recurrent ERM going forward. So that's the purpose of doing the triple peel in these kind of situations. Question is, what visual acuity should be expected after macular hole surgery, and what is the recovery period? Dr. Bola? What visual acuity should be expected after macular hole surgery, and what is the recovery period?
So it depends. The most basically that's asking prognostic indicators and factors. And those are the main ones is time. So usually if the patient presents below 6 months of the formation of the hole, we can't really tell when the hole forms. So what we use is symptomatology. If the patients have symptoms for less than 6 months, that's a good prognostic sign. If the patients have a stage 2 hole or an early hole, that's a good prognostic sign. If their starting vision when you do surgery or just before you do surgery is 618, 612, they're starting with good vision, you'd expect them to improve by 1 or 2 lines. That's the general improvement number that you get on Snellen testing. So what you find is patients who start off with an early hole or a good vision, maintain good vision and get improvement in their vision. The other good thing about early holes is that the closure rate is really, in some studies, 99%, and in some studies, about 95%. So it's very high surgical success in the early holes. It's the late holes that we have a real issue with and problem. If a hole has, or a patient has symptoms for more than 1 year, then we start to think that the prognosis for improvement in vision is much lower than what we get at the early holes. Usually we start to tell them, you know, there's a 50% chance, there's a 60% chance you might get a line or two improvement in your vision, especially if they come in with this big macular hole, 660 vision. Really, some of those, I tend to tell them, you know, there isn't a lot of benefit for you doing surgery here. So macular hole, choosing the patient, the right patient, is really not simple. It really is dependent on the assessment that you make and also on the patient and the discussion that happens with the patient. So it's a little bit of a long discussion that goes on, and also you need to give the patient time. So we usually tell them, go away, think about it, come back and let's chat again. So we usually have to do it in a little bit of a phased approach. You know, very interesting.
Thank you. Yeah, thank you. I hope that answered Gerald's question. Daniel has asked a question: can epiretinal membranes be picked up on visual field test? As far as I'm aware, no is the answer. Do you have any comments on that, Dr. Bola? Can epiretinal membranes be picked up on visual field tests?
Well, I don't think it can be picked up on the 24/2 field test, you know. And I would also say that it is not the right test. It's not the right test. Yeah, you really want to look at what it's doing to the layers in the retina, because that's going to give you information to help you to decide what to do with it. You know, if you pick up a field effect, like if you did a central 10-2 and you picked up some field effect, I think you have to think now, is this another pathology going on? Because the ERM really shouldn't give you a change in your field of vision. So you have to now think, is this you know, nerve pathology here or something else going on?
Wonderful, wonderful. I think that's a good discussion we've had. And in view of time, and I'm really impressed that we still have 90+ people still hanging on at this hour. But I would start off by saying, before we close this meeting, thank you for all the participants who turned up for the meeting and participated actively in this meeting. And to all the presenters who've taken a lot of time and effort in presenting the cases, thank you very much. I would close by just summarizing some things, particularly what we started off with is we've understood today about vitreomacular interface problems, epiretinal membranes, macular holes, lamellar holes. We've all learned how to identify it. We've learned about the techniques to identify it using color fundus pictures, fundus examination, OCT assessment. And then we've also gone on in certain challenging cases where an OCTA, that is angiogram, or a fluorescein angiogram is relevant. And as Dr. Boehringer pointed out, in some cases there are challenges such as a drusenoid deposit, which might require ERGs or EOGs, electrophysiology tests. And that's also important to understand. So it covers the gamut of retinal tests that we tend to do. And then we've learned as to what are the interventions. We've spoken about no treatment, observation, education of the patient, intervention with surgery, which is conventional. We've spoken about different options that we have for treating macular interface problems. And as Ibrahim pointed out, and the purpose of our discussions and meeting like this and using the WhatsApp platform is shared care. We need to work together towards better care for our patients. We need to work together to have a better understanding of the problem. We need to work together to say that we're all in together providing better care for individuals and get the best visual acuity for these patients. On that note, thank you once again. Be safe and take care of yourself and your families. And thank you for your participation, everyone.